Whenever an operation is done on a patient, we want the patient to not have any pain. We want the operating part of the patient's body to be immobile. Welcome back to Ophthalmology for undergraduates and postgraduate beginners. Today, our topic of discussion is anesthesia for ophthalmic surgeries. Anesthesia in ophthalmological surgeries is of two types. One is general anesthesia, another thing is regional anesthesia. General anesthesia is indicated in children undergoing surgeries, in mentally unstable patients undergoing surgeries, in case of prolonged surgeries like retinal surgeries, oculoplastic surgeries, in poorly cooperative patients, you should give a general anesthesia. General anesthesia is usually given by a anesthetist, because the anesthetist is going to give the general anesthesia for your patient. The ophthalmic surgeon can concentrate on his surgery without having any tension about the vitals of the patient. Regional anesthesia or local anesthesia is the commonest anesthesia given in ophthalmic surgeries. This anesthesia is usually administered by an ophthalmologist because we don't expect much problems in the physical condition of the patient in case of regional anesthesia. There are several types of regional anesthesia given in ophthalmology, the commonest being the peribulbar anesthesia. So, more than 50% of the cases, peribulbar anesthesia is being given. The next commonest type of anesthesia given nowadays is a topical anesthesia. The third type of anesthesia that is being given is the retrobulbar anesthesia. This retrobulbar anesthesia, those days, it was the only type of anesthesia given for ophthalmic surgeries. But nowadays, because of the increased complications caused by this type of anesthesia, it is not being followed by many. Only experienced surgeons, they give this retrobulbar anesthesia. Whenever you give a retrobulbar anesthesia in a patient, you should also give a facial anesthesia. Then only you can operate on the eyes. First, talking about the topical anesthesia given for ophthalmic surgeries, the drugs used are 4% lignocaine or 0.5% proparacaine solution. It is administered every 5 minutes for 3 times. Whenever you give a topical anesthesia, you should make sure patient is well educated and patient will cooperate for your surgery. Whenever you do a intraocular surgeries like cataract surgeries, you should anesthetize the iris inside also. The iris is a very sensitive structure. If you happen to touch the iris with this topical anesthesia, the patient may have a severe pain during surgery. In order to avoid that, we can inject intracameral lignocaine. Intracameral means into the anterior chamber, we inject the lignocaine so that the iris gets anesthetized. Usually, topical anesthesia is preferred by ophthalmic surgeons in case of phacoemulsification surgeries. It is not preferred in other types of surgeries. Topical anesthesia is also used in foreign body removal on the cornea and conjunctiva. Commonest type of anesthesia given in ophthalmic surgeries is peribulbar type of anesthesia. What is this peribulbar anesthesia? So I have drawn an orbit here. The eyeball is in the orbit. You see these red color lines, these are the extraocular muscles. When you give the anesthesia outside the extraocular muscles, that is called as peribulbar anesthesia. How much of anesthesia is being given? Roughly about 5 ml of anesthesia is needed for anesthetizing the eye. It is given at two sides, one is above, other is below. Above you give 2.5 ml. If you see on the medial aspect of the superior orbital margin, there will be a orbital notch will be there. So in that portion we inject this 2.5 ml. We go along the roof of the orbit and inject 2.5 ml. We use a IM needle, intramuscular needle, which is a thin one and it is a short one. When you give below, it is given at the junction of medial 2/3 and lateral 1/3 of the orbit. At the junction, along the floor of the orbit, we go inside and we give 2.5 ml there. So, this anesthetic agent has to slowly spread in the peribulbar area and it has to infiltrate into all the structures of the orbit to make them anesthetized. So, it will take roughly 5 to 10 minutes to get this anesthesia to an effect. What are the things we give for or we use for giving a peribulbar anesthesia? We use two drugs. One is the 2% lignocaine. So it is available in 30 ml vial. Into that 30 ml of 2% lignocaine, we inject 1 ml ampule of 1 in 1 lakh adrenaline into it. Within that vial, we are going to inject one more substance that is called as hyaluronidase. So, for a 30 ml vial, we have to inject about 450 units. That is 150 unit per 10 ml. So, 450 units we have to inject into this vial. We have to shake it completely. And from that vial, we have to take 2.5 ml. Another drug used for peribulbar anesthesia is bupivacaine 0.5%. Sometimes you may have a 0.75%. You take 2.5 ml of this bupivacaine also, you mix them and you make it 5 ml. Then we are going to give this peribulbar anesthesia. Why we should inject these two solutions? You know that lignocaine acts very fast. Within 5 to 10 minutes it will take its action and the anesthesia will last for 30 minutes to 2 hours. Bupivacaine will take 20 minutes to begin its action, but that may act for a longer time, up to 6 to 8 hours. So it will give a longer anesthesia. That's why we mix them too. Now you will be asking why we are using adrenaline. This solution, 1 in 1 lakh solution, is being used because we are giving into the orbit. We want to constrict the vessels in the orbit. If the vessels are constricted by this 1 in 1 lakh adrenaline, what will happen is the anesthesia will stay in the orbit for a longer time. It will not get absorbed into the bloodstream, so patient will have a longer anesthesia. Why do we use this hyaluronidase? This is being used because this is an enzymatic substance. When you are giving anesthesia, this enzyme will make the drug to penetrate faster into the orbit for the anesthesia to take its effect as soon as possible. That's why it is being used. Peribulbar anesthesia is one of the least complicating type of anesthesia. Very few complications occur. The commonest complications are, if you are not going to give it along the bone, sometimes you can perforate the globe. The anesthesia or needle may prick into the globe and it may go into the eyeball. That is the commonest thing. Sometimes you can injure a vessel here, so what will happen is there will be a bleeding that will lead to swelling of the lids, ecchymosis or subconjunctival hemorrhage that can occur. Sometimes when you touch the extraocular muscles, it may lead to a oculocardiac reflex and suddenly there may be a cardiac shock. So we have to monitor the patient while giving anesthesia. After giving this anesthesia, you have to massage the eyes intermittently for 5 to 10 minutes. Massage the eye intermittently for 5 to 10 minutes to make the anesthetic agent to spread faster and to take its effect, and also to make the globe softer for doing a surgery. If the globe is very much tensed up, then surgery will be very, very difficult. The third type of anesthesia most people nowadays don't prefer is a retrobulbar anesthesia. Retrobulbar anesthesia, you inject the anesthetic agent behind the eyeball within the muscle cone very close to the optic nerve. For this anesthesia, we need a longer and wide bore needle, that is the IV needle. So it will be about 35 mm in length. So such a type of needle is needed to inject the anesthesia here. We need 2% lignocaine as an anesthetic agent. Only about 1.5 ml is enough to get this anesthetic effect. We need not give so much of anesthetic agent here. When you inject here, in this area you have the ciliary ganglion. The ciliary ganglion gets anesthetized immediately. So the entire eyeball become anesthetic by this injection as soon as possible. Very early it will become anesthetized. You can see the lids coming down, that is ptosis, as soon as you give the injection. So that kind of anesthesia it is. But nowadays this anesthesia is not practiced because of so many complications. What are the complications? When you are giving the drug close to the optic nerve, the needle may prick the optic nerve. The patient may go blind because of the damage to the optic nerve. You can inject the anesthetic agent into the subarachnoid space between the optic nerve and the meningeal sheath. So what will happen? This anesthetic agent will spread around the brain. It will cause convulsions. It will anesthetize the brain, leading to a cardiogenic shock, and the patient may die. The vessels close to the optic nerve may be injured and they will start bleeding, leading to a heavy bleeding behind the eyeball, that is called as retrobulbar hemorrhage. Once there is a heavy bleeding, the eyeball will get proptosed, it may come out. So that kind of complications can occur. The next common complication is the central retinal artery may get occluded, leading to loss of vision. Sometimes this needle, if you don't direct towards behind the globe, it may perforate the globe and cause anesthesia of the eyeball and you may lose the vision. So many complications are there in retrobulbar anesthesia. Nowadays don't prefer this type of anesthesia. Whenever we want to give a retrobulbar anesthesia, we also want to give a facial nerve block. Because when you give a retrobulbar anesthesia, the orbicularis oculi muscle does not get anesthetized. It will constrict and make the surgery difficult. You want to anesthetize this orbicularis oculi muscle also. In peribulbar anesthesia, because you are giving the anesthesia around the muscles, the orbicularis oculi muscle also will get its share of anesthetic agent and it will get anesthetized. But in retrobulbar anesthesia, it is not so. So we have to give a facial nerve block in retrobulbar anesthesia. There are two types of giving it. One is blocking the entire facial nerve on the side of the face. So that is called as O'Brien technique, where you can inject the anesthetic agent lignocaine 2% 4 ml. If you open and close your mouth, you can see the neck of the mandible moving. So you can see here. So in that area in front of the tragus, you have to give 4 to 5 ml of anesthesia using a shorter needle. Okay, so that the facial nerve is blocked. You can also block the facial nerve supplying the orbicularis oculi muscle alone by practicing this Van Lint technique. Van Lint technique is nothing but 1 centimeter lateral below to the lateral canthus. We prick the needle. We take 4 to 5 ml of 2% lignocaine and we go below the skin subcutaneously above and we inject 2.5 ml there and we change the direction, go below and inject 2.5 ml here, so that the full portion of the orbicularis oculi muscle gets anesthetized, so its action will not cause any problems during the surgery. With this, we will stop here today. We have talked about anesthesia in ophthalmology and we will continue with the other topics in the next session.